Hey everyone, welcome and thanks for joining us for the next masterclass focusing here on the knee. So if you've been to or tuned in and watched the recordings of prior masterclasses, you're going to see one or two similar PowerPoint slides early on during this masterclass, just to go through our general thought process, our general approach that would help form a foundation for the objective measurements and the rehabilitation strategies that we go through later on in this video. So we're going to talk through our neuromechanical lens. We're going to talk through some local and global features, then dive into the local segmental interactions that represent the knee. Then we're going to go into some assessment strategies. We're going to go into some case scenarios, discuss the subjective and objective assessment features of both those case scenarios, and then use those to develop a thought process to guide the implementation of certain rehabilitation strategies across these two different cases. Okay. Now, in prior master classes, we have focused a lot on what's going on proximally at the pelvis, the femur, for example. We have focused on in the last masterclass, we focused on the knee, the foot and the ankle. So a lot of those rehabilitation strategies and the assessments that we use in those two masterclasses would be also very important to consider when we're looking at the knee. But in this masterclass, we want to try and keep it focused on the knee and look at the local contractile behavior of the muscular tissues, the local joint segmental interactions across the knee complex to help guide what's going to happen from a rehabilitation standpoint and talk about the sequencing of rehabilitation and loading strategies for the local structures around the knee. We will certainly integrate what's happening proximally and distally as well, but we do want to try and concentrate a bit more focus locally at the knee here. Okay, so diving into our kind of overarching approach. So we use very much a neuromechanical lens that focuses on the interaction between the nervous system, the anatomy, and the environment. So when we look at the anatomy, we're looking at muscular and joint interactions for the most part. Okay, obviously it's a lot more complex than that, but we want to have an understanding of the anatomy in a way that simplifies how we're going to implement rehabilitation. So if we start to look at too many variables across the anatomy, sometimes it can make it very complex and make it more difficult to establish and determine what kind of rehabilitation or loading strategy the client may need. So if we look at muscular and joint interactions, this can help give us a better understanding of how the nervous system is interacting with the anatomy, because ultimately it's the muscles that receive the motor signal from the nervous system. Okay, so the nervous system delivers motor output to the muscles. The muscles move the joints. Okay, that's neurology 101. But we can also see a change in kinematic variability, so joint segmental variability. But for a joint to be able to move, there needs to be a certain behavior at the muscular tissues before that joint moves. If we have a large amount of muscular activity or co-contraction around the joint, that joint's not moving. Okay, so we need to ultimately change the muscular behavior first before we change the joint segmental behavior. But it doesn't mean that looking at joint segmental behavior isn't important. We can look at joint segmental behavior, but we need to appreciate that this will be the result of a change in muscular behavior as well. But we, as you'll see in the assessment component of this masterclass, is that we will put a large emphasis on what's happening from a joint segmental standpoint. But we need to look at that joint segmental behavior and appreciate what's happening from a muscular standpoint as well, because muscles are very complex. Throughout the body, we have many, many muscles that carry out similar functions. So there's a lot of what you may see in older motor control or motor learning research is you'll see this concept called motor redundancy, which means that we have muscles that can carry out similar tasks. Okay, lots of muscles that do similar things. So if we look only at the muscular tissues to guide what's going to happen from a rehabilitation standpoint or to guide our assessment process, then because there's many, many options that are many functions that similar muscles can carry out, sometimes it can become very complex to help guide a more clarity in your thought process when you're trying to determine what the client might need from a rehabilitation standpoint. Then we need to consider what's happening from the environment, the external forces impacting our anatomy from the external environment. There's some key universal features here that we need to consider, that the distal endpoints of the limb are the components of the limb that are interacting directly with the external environment. So the foot and the ankle is really the region of the lower limb that's interacting directly with the external environment. The knee is acting indirectly with those external forces, but the knee will still have to express certain muscular and joint behaviors to help facilitate a lower limb that can help appropriately manage and generate forces. Sometimes the forces impacting our lower limb are very low, then the knee may not have to move through a large amount of flexion at all. But if the forces are very high, then we need that knee to express more flexion capacity to create more muscle length and more joint angle changes to spread those forces or distribute those forces over a broader surface area. When joint angles move, when muscle length changes, it gives our system more time to manage forces and distribute forces. If we keep the knee very stiff and braced and express a co-contraction when we should be flexing the knee, then this is what can I don't want to say cause trouble, but it can definitely limit our capacity to appropriately manage and generate forces. Okay, and we're going to talk about those features in a little bit of detail as well in the masterclass. We need to consider what's happening from a distal to proximal and proximal to distal standpoint. So when we're managing forces from the external environment, it's more of a distal to proximal focus, where we're managing forces distally, those forces are being distributed proximally. When we're generating forces, this is usually expressed in more of a proximal to distal manner, where we're using the larger muscular tissues with more muscular mass proximally to generate forces and act on the environment. So these represent two different strategies or intentions that the anatomy, the nervous system, will express, but it's secondary to the task constraints. So if the constraints of the task are to generate forces, high forces, we may utilize more of a proximal to distal strategy. If the task involves more force management, then we may want to focus on more the flexion capacity of the lower limb, where we're using flexion of the ankle, the knee, and the hip to distribute forces and manage forces appropriately. Okay, so looking at that here in a little bit more detail, when we're looking at distal to proximal strategies, we're looking at how the environment is influencing the anatomy, and then what kind of behavior the anatomy is expressing, and how this gives us an insight into how the neurology, the nervous system, is coordinating the control across the anatomy. So it expresses more of a disturbance control feature. Controlling disturbances are the same as perturbations. How do we control perturbations acting on our system from the external environment and distribute those forces? So if we look at the knee, for example, we're looking more so at knee flexion, which involves the tibia's capacity to be able to flex, but also the femur's capacity to be able to flex, and an internal rotation of the tibia. Okay, how much knee flexion is necessary is dependent on the forces that are impacting your system, but also on the capacity of the knee as well. If the knee doesn't want to flex, but you still need to be able to manage high forces, it's going to find another way to decelerate or manage those forces. And that's often when we can see this valgus representation, this dynamic valgus representation. It's just a faster way to decelerate forces. Okay, very, very similar. And we spoke about this recently on our Instagram. Very, very similar to what's happening at the foot and the ankle. If you watch a sprinter running 100 meters as fast as they don't want to spend too long on the ground. So you're not going to see them sink into a lot of dorsiflexion, but they still need to be able to manage the collision with the ground. So you'll see them manage that collision with the ground and manage those forces through the rotational movement of the foot, through pronation, because it's a faster way to decelerate those forces while still keeping the ground contact times low. If they were to manage that through the sagittal plane of the ankle, through dorsiflexion, they're going to be much slower. They're going to spend longer on the ground. Okay, so dynamic valgus is not a bad thing. It's a faster way to decelerate forces. What I don't want to say what makes it bad, but what limits our capacity to manage forces, what limits the variability in our movement behaviors to be able to manage forces, is if dynamic knee valgus is the only strategy we have, and we don't have the capacity to flex the knee at speed and manage forces through the distal quadriceps at speed. We need to develop that capacity. Okay, so if you have a client that is expressing a lot of dynamic knee valgus, not necessarily a bad thing, but they also have an inability to manage high forces through knee flexion and allow the distal quadriceps to be able to manage those forces, then we have a problem. Then we have a lack of variability in the behaviors that the knee can express to manage and generate forces. If we look at things from a proximal to distal standpoint, we're looking at how the nervous system is acting on the anatomy and how the anatomy then is acting on the environment. So it's more of a force production, force generation perspective. We always need to generate forces. So we're still generating forces to even manage disturbances, but the intention isn't necessarily to overcome those external forces. We still need to be able to generate force, but with the intention of managing, yielding, distributing those forces. Okay, so the focus here from a local perspective around the knee, for example, would be looking at knee extension, which involves the ability of the tibia to extend, the femur to extend, and the tibia to externally rotate. It, of course, involves much more than that. There's obviously going to be a coordination of extension across the lower limb, across the ankle, the hip, that we need to consider as well. Okay, so ultimately, these interactions really help guide how we structure the restoration of variability. Okay, and we can look at variability through two different lenses. We can look at it from a muscular standpoint and a kinematic or joint segmental standpoint. We need to always appreciate both. So if we dive into the local and global features, we like to separate features from a local and global or coordinative standpoint here. From a local standpoint, we're looking at the local interactions around the joint complex in question. So of course, we can look at what's happening between the ribcage, pelvis, femur, tibia, and also the patellar femoral interaction as well, and the interaction between the tibia, the foot segments, and look and appreciate the muscular contractile capacities around those individual interactions as well. But we're really looking at intersegmental coupling here. So around the knee, we're looking at the interaction between the tibia, the femur, the tibiofemoral joints. We're looking at the interaction between the patella and the femur, the patellofemoral joints. But we're also looking at the local interactions, proximal and distal as well, because let's say, for example, you have a client that comes to see you with a current experience of anterior knee pain, and there wasn't any clear mechanism of injury, but the year prior they had an ankle sprain, and they may have a limitation in joint segmental behavior locally around the ankle. That limitation in space, if you like, around the ankle joint, the inability to flex the ankle and distribute those forces at the ankle joint may have an influence on what the knee has to do to be able to manage those forces. That may overload the knee, and the knee may not be conditioned to manage those forces. That may influence the sensitivity around the knee, and so on and so forth. So we need to consider what's happening distal and proximal to the knee. So we need to obviously dig into the client's subjective assessments, subjective information, and that can help guide what's happening or what we do from an objective standpoint as well. We don't only want to use pain to guide our assessment. We need to look at what's going on subjectively, use that to guide our objective assessment, and then couple those two assessment pieces together to really guide appropriate rehabilitation. Okay, so looking at things from a joint segmental standpoint, looking at things from a muscular or contractile standpoint as well. When we're looking at the knee, we're looking at distal quadriceps, distal hamstrings, the proximal gastrocnemius, for example, are all important to be able to express a certain behavior around the knee. But we'll talk about that in the next video here, or the next slide here. We have a video here that talks about this inability to control tibial extension. Because one of the key joint segmental features around the knee is that when you bring the knee back into foot extension, where the tibia externally rotates and expresses that screw home mechanism, is that brings the knee back into a close packed position where there's less variability at the knee, at the tibiofemoral joint. Sometimes if the client lacks the ability to handle forces around the distal hamstrings, the proximal gastroc, or the distal quadricep, is they will express that close packed position much more often, or they may quickly shift into that close packed position where they express less variability. And this may represent that the muscular tissues don't have the capacity to coordinate well around the knee. And so that's something that we need to influence. Okay, it doesn't mean that we're not necessarily trying to improve knee extension. We of course are trying to improve that when it's necessary. But from a variability standpoint, we want to allow the muscular tissues around the knee to be able to manage and generate forces while the knee expresses some level of flexion where it has more variability. Okay, where the tibia can interact with the foot in a way that allows us to distribute forces and loads well around the whole foot. If my knee is locked back into extension, it's going to be very difficult to shift that load into the metatarsal heads, where we need to be able to allow for the plantar flexors to even engage. If your weight's always in your heel, you're not really engaging the ankle plantar flexors to be able to manage and share forces there. Okay. From a global or coordinated perspective, we're looking at the body region as a whole. So we're looking at the midline relative to the lower limb. Okay, so we're looking at, again, from a global coordinative standpoint, we're looking at the whole limb's ability to be able to manage and generate forces. And we're looking at the whole midline's ability to be able to manage and generate forces. Okay. From a global standpoint, we want the limb to have the capacity to manage and generate forces, because it's ultimately the limb that's in direct contact with the external environment. The midline is not in direct contact with the external environment. So that's a key universal feature that we need to consider there. If we want to have diversity in movement behavior, we want body regions to have different behaviors. So we don't necessarily want the midline to express certain muscular behaviors that are always trying to manage forces. We want to give the midline the chance to express some adaptability, so the lower limb can express those capacities to manage forces. And that's how the limb is really set up. The limb has a very different segmental organization to the spine. So we have a lot of segmentation around the foot and the ankle, for example, but as we move into the tibia and fibula and into the femur, we don't have a lot of segmentation. But then as we move proximally into the spine, we have a lot more segmentation. So the distance between L4 and L3 vertebrae is much smaller than the distance between the tibiofemoral joint and the hip joint, between the pelvis and the femur. Okay, so the much larger distance there. This reduces the complexity of control, if you like. So imagine the femur was segmented like the spine. It'd be impossible to control our body, because there would be so many muscle length and joint angle changes occurring with every step. So we need to have some simplicity in the face of a complexity to make it easier to control for the nervous system to distribute control across the anatomy as well. So you can almost think of it as this interaction from proximal to distal between very complex joint segmental architecture, if you like, and then much more simplified organization from a joint segmental standpoint. And then we have more complex organization again in the local segmental interactions around the foot complex. Okay, that movement from complex to more simple organization to more complex again is a very important distribution, because again it offers a system much more variability in how it can manage forces. But again, it encourages us to think about the associated joint and muscular features. So from a muscular standpoint, we'll focus on this here, and then we'll move into the next slide. So on a muscular level, if you look at the amount of muscle mass distributed proximally versus distally, we have much more muscle mass distributed proximally versus distally. Okay, we have much longer free tendons distally through the Achilles tendon, for example. That's important for energy storage. Same thing with the patellar tendon, not involved in as much energy storage and release like the Achilles, but still very important from that perspective relative to the tendon architecture proximally. We have a lot less muscle mass distributed distally. And one of the key reasons for that is because it reduces the inertia of the lower limb. So if we had a lot of muscle mass around the foot and the ankle, imagine how difficult it would be to move around all day if we had a muscle like the glute around the foot and the ankle. It would just make the ankle heavier, okay? Which is just, it's going to be much more difficult to interact with our environment in that way. So ultimately, when we have these long free tendons distally, and we have muscular tissues that have shorter fiber lengths, like the gastrocnemius and soleus, for example, it represents to us that these muscular tissues are designed to specialize, are specialized to work towards more isometric behaviors, to be able to quickly manage the perturbations and forces acting on our system from the external environment. It's about that quick responsiveness to those external forces. So if you had a muscle that has a very long fiber lengths, like the glute max, located on the ankle, that muscular tissue is not going to be very responsive to those external perturbations. So the system is really designed for efficiency in this regard, to be able to manage perturbations and manage disturbances. Okay, so we need to respect that, and we need to integrate that into our assessment and rehabilitation approach. Okay, so moving into the local segmental interactions. Of course, we mentioned this lower midline, lower limb interaction, where we're looking at the midline body region relative to the lower limb body region. So we have the interaction between the rib cage, pelvis, femur, tibia, foot segments. But when we're looking locally at the knee complex, we're looking at the interaction between the tibia and the femur, the TFJ, tibiofemoral joint, and we're looking at the interaction between the patella and the femur, the patellofemoral joint. So how might these present differently from a clinical standpoint? So very often, if you have a client come to see you with a current experience of knee pain, and they point to the medial and lateral portion of the knee around the joint lines, then typically you're going to be more interested in the sensitivity between the tibia and the femur. You're considering that, or interested or suspicious of potential sensitivity to contact forces at the TFJ. Whereas if the client experiences more pain deeper into knee flexion, where there's more compressive load between the patella and the femur, then you may consider the PFJ. They might point to the anterior portion of the knee. It may be may pop up in different areas around the kneecap, maybe superior, medial, lateral, inferior to the kneecap. But again, typically when it comes to the PFJ, they're going to feel more discomfort or feel more pain into deeper levels of knee flexion. They may feel more pain coming downstairs, for example, when there's going to be a lot more kind of load through the knee extensor mechanism, through the anterior knee. So you need to be considerate of that. And just to point out one other kind of clinical feature that we often see is that very often when we have a client that points to the medial or lateral portion of the knee, not necessarily into the anterior knee around the kneecap, we're often very suspicious of a client that is managing forces through the knee with a very stiff or braced knee, where they're not really moving that knee well beyond 20 to 30 degrees of knee flexion. They may demonstrate a lot of co-contraction around the muscular tissues around the knee, the distal quadriceps, the distal hamstrings, the proximal gastrocnemius. And what this does is it increases the contact stress or the contact force between these two joint surfaces. We're not saying that it's causing a meniscal tear. Of course, we need to have these things on our radar as well, but we're looking at the sensitivity to forces between two interactions. That's what we're looking at here, okay? Oftentimes you may see a client with a very braced or stiff knee use valgus at the knee as a way to decelerate forces, because the distal quadriceps may not be able to manage those forces. So they have to decelerate the knee using another strategy. But then the complexity of this is that when we move into dynamic knee valgus, we're going to increase the compressive load between the PFJ. So it's going to put a bit more load and sensitivity, or potentially create sensitivity to forces at the PFJ. It doesn't mean it's going to create a sensitivity, but what's important to consider there is the client's capacity to manage those forces. Are these structures, are the muscular tissues around these structures conditioned to manage forces in those areas? Okay, that's what makes things complex in the sense that, I think a lot of times therapists may think of any kind of knee pain as the knee being overloaded. Okay, but it's not always that simple, because they could be expressing a lot of co-contraction around the knee joint by heightened levels of muscular activity through the distal quadriceps, distal hamstrings, proximal gastroc, for example, secondary to a distal quad that can't manage forces very well. So if you don't restore the capacity of the distal quadriceps to manage forces so the knee can flex through a greater range and distribute those forces well across the knee joint, and you're only doing hip strengthening or ankle strengthening, then you may be missing a key part of the puzzle there. Okay, so it's very important to consider what's going on locally around the knee and consider what's happening from a local segmental standpoint too. So in this next video here on the right-hand side, we're going to give you an insight into this uncontrolled tibial extension. And I do have to state that what you're going to see in this video here is a very exaggerated example of uncontrolled tibial extension. You're often not going to see this in your clients, but I think it gives us a nice representation of what we're actually looking for. So as that right leg hits the ground there, we obviously want to transition that force from the heel to the forefoot, but we want that tibia to express the capacity to maintain some level of tibial flexion to bring that load into the metatarsal heads, which makes it easier then to propel our body weight forward. Okay. But what you're going to see here is this inability to maintain some level of tibial flexion. And you're going to see this quick snap back shift into tibial extension. When you see that, what happens there is the weight shifts back into the heel. And again, we can't necessarily use the extension of the foot segment to propel us forward, but we have to use a more proximal leading strategy where you'll often see clients using the spinal extensors as a trunk leading strategy to propel our body weight forward or to progress our mass over our foot segment. Okay, just to go back through that again. But why might this be happening? As that tibia flexes forward, there is going to be a challenge on the ankle plantar flexors here. as that load goes into the metatarsal heads. Potentially, if the ankle plantar flexors don't have the capacity to manage that force, we're going to see this quick shift back into the heel. Or it may be secondary to I'll just run that for a second. It may be secondary to an inability of the distal hamstrings and proximal gastroc to decelerate or slow down that femoral extension and tibial extension into knee extension. Okay, so we may have to look at the low capacity, the isometric eccentric low capacity of the distal hamstrings and proximal gastrocnemius when it comes to the distal ankle plantar flexors, or the extensors of the foot segment, and the deceleration of the forward translation of the tibia. We're looking more so at the soleus here as well, but also the gastrocnemius. But we can't forget about the importance of the distal quadricep, because as that tibia flexes, to keep that tibia flexed and to prevent the tibia from flexing even further, because as that tibia flexes, there's going to be a little bit more gravitational load down through the behind the knee joint to try and flex the tibia even further from the mass of the head, arms, and trunk, and from gravitational forces, and also from the ground reaction forces below as well. So if the distal quadricep can't maintain that tibial flexion, what you might see is this very quick snap back into extension at the knee. So it may reflect what you're seeing here in this uncontrolled tibial extension is it may reflect different muscular capacities. So we need to be aware of all of them, okay? We can't just be considering one muscular tissue. We need to be aware of all of them. And just in the next video here, I just want to take a look at or give you an insight into the patellar and quadricep interactions here as well. So as you'll see here, during the early phases of tibial flexion, you're going to see a lot more length change in the patellar tendon. This can be important because sometimes you might have a client that experiences localized pain with palpation or with more kind of loaded activities, elastic activities like jumping, a pogo hop, for example, where there's not going to be a huge amount of knee flexion, but there's going to be some level of knee flexion, a little bit of tibial flexion. If they experience pain there, you're going to be, or you should be suspicious of the low capacity of the patellar tendon. So you see that a lot more length change there. But then as we go deeper into knee flexion or tibial flexion, you're going to see a much greater length change at the quadriceps tendon. Okay. So you'll see that there again. So much more of the length change during the early phases of knee flexion is going to be at the patellar tendon. During the later phases, it's going to be more so through the quadriceps tendon. Okay. That can be important, when you have a client that has, pain above the knee in deeper levels of knee flexion, or pain below the knee during lower levels of knee flexion. So we just need to consider all these features. Okay. I know it might seem like a lot, but again, we need to simplify the assessment process as well. And that's what we're going to go through next. Okay, so moving into the assessments. So during the assessment process, there may be certain assessments that we use early on during the assessment process, like session 1, session 2, for example. And then towards the end of rehabilitation, depending on the client's goals, if they're returning to play, if they're returning after, an operation to the knee, where they had a very weak distal quadricep, where the distal quadricep wasn't able to manage and generate forces very well, then we may have to use other assessments to get a general insight into the distal quadriceps ability to manage and generate forces. We're looking at knee flexion and knee extension first, or tibial flexion and tibial extension. So typically we're measuring this in a supine position, passively. So what we'll do is we'll grab the calcaneus, we'll stabilize the femur, we'll passively move the tibia back into flexion, and we're trying to get the calcaneus or the heel to the glute. Okay. To do that, we need the tibia to be able to internally rotate, and that will allow for the femur to express more external rotation relative to the tibial internal rotation. But we also need the distal quadricep to have the capacity to express eccentric contractile behaviors there. Okay. When we're looking at extension passively, we're looking at the tibia's ability to externally rotate relative to an internally rotated femur. Now, this is important to express that screw home mechanism, but we also need the distal hamstrings, for example, the proximal gastrocnemius, to express that eccentric behavior as well. Okay, there's other muscles that need to lengthen here too, but those are two key ones that we need to be able to express the capacity to lengthen. Okay. Now you may also have to look at tibial internal rotation and external rotation in isolation as well to get a better insight into what's happening between the tibia and the femur. But what we'll often do is look at supine and prone assessments here of tibial flexion specifically, because very often you'll have clients that have sensitivity around the knee, sometimes through the anterior knee, sometimes through the medial and lateral knee, as you're flexing the tibia in a supine position. But when you go into a prone position, they may be able to move further into flexion before they experience that pain, or they may be able to move through a much greater range of motion, maybe full range of motion in a prone position. Because what you're doing in a prone position is you're allowing the rec fem to lengthen much more. So you're giving the knee a greater chance to spread the load into the rec fem, whereas the supine position will give us a more focused assessment on the structural interaction between the tibia and the femur. So sometimes if you see a lot of sensitivity, discomfort through the knee, what that represents to us, and what we see very often with this, is that the client is expressing a very stiff and braced knee to move, okay, where there's a lot of co-contraction through the distal quadriceps, through the distal hamstrings, and through the proximal gastrocnemius, when there's a lot of restriction in tibial flexion measured in supine. Now, of course, we need to consider meniscal tears, we need to consider other structural changes as well. But from a movement variability standpoint, this is what we tend to see. And this tends to be coupled with an isolated limitation in tibial internal rotation as well. So we need to break out and look at that in isolation too. But generally, if you have a pain experience when you're measuring tibial flexion passively in a supine position, I would encourage you to do it in a prone position as well, to see if what you're seeing is just an expression of a heightened level of co-contraction through the muscular tissues around the knee, and they just need to express more length change, muscle length change, more joint angle changes to spread that load over a broader surface area. Okay. So then we're moving into more kind of active assessments. Okay, now this isn't, the assessments that we're going through here aren't representative of all the assessments that we would use. We would use different assessments for different clients depending on the subjective information that they've given us. But if, for example, if you're watching a client walk, for example, and you're seeing that very quick snap back into tibial extension, another assessment that we can use is a soft knee calf raise. So what we're doing here is we're asking the client to bend the knee slightly, around 10 to 20 degrees, which will bring the knee from a closed pack position into an open pack position, where there's a little bit more variability at the knee. And we're asking them to maintain that position as they drive down through the toes to raise the heel off the ground. So we're just seeing, can they generate force at the ankle through the plantar flexors and maintain that variability at the knee? Okay, so what we want to see is something like this. And it's a lot harder than it looks for clients that have a current experience of knee pain. But what you'll see is something like this, where you'll see that shift into tibial extension, that inability to maintain slight tibial flexion as they extend the ankle. So again, it's a very coordinative test, if you like, because we're asking the client to maintain a certain behavior at the knee while we generate forces at the ankle. Okay, this is coordination in a nutshell. It's the ability to express different behaviors and allow for a sharing of workload across interacting muscles, interacting joint segments, interacting body regions. Okay, we want a distribution of workload, because in reality, that's what's happening across the lower limb during real world movements. We want to be able to manage forces and generate forces as well around the ankle and the foot. Sometimes we don't need to generate a huge amount of force around the knee. Sometimes we just need to be able to maintain a certain level of variability at the knee. But if the knee is very quick to snap back into extension, where it's expressing less variability, then that tells us an awful lot about how that knee is behaving within the context of the rest of the lower limb. And that can inform us, or that can help guide us as to what potential strategies we may need to use or may need to work towards from a rehabilitation standpoint. Okay. Now, looking at this small knee bend assessment, where we have the client in a single limb stance position, what we're doing is we're asking them to bend the knee slightly. And if you see you'll often see a valgus representation like this with this scenario. But what you also need to consider, things from two different perspectives: a kinematic perspective and a kinetic perspective. Kinematic perspective is, are we seeing that that greater level of internal rotation and adduction at the femur, for example, because the foot segment is dragging it into internal rotation. So if a client has a very pronated foot, for example, where they're struggling to express supination of the foot, inversion at the calcaneus, plantar flexion at the ankle, you may see that femur getting dragged into adduction and internal rotation. But from a muscular standpoint, we need to appreciate this as just a strategy to decelerate knee flexion. That's all it is. It's a strategy to decelerate knee flexion. This representation that you're seeing here is completely fine. I would have no problem with it, as long as the client also has the ability to manage and generate forces into deeper levels of knee flexion through the distal quadriceps. Okay, because if you have a client that's always expressing this dynamic knee valgus, but they really struggle in deeper levels of knee flexion to manage and generate forces through the distal quadriceps, then I don't think that's a good situation to have if this is your only deceleration strategy. But if you're seeing this, what I think the knee-jerk reaction is for a lot of therapists is to try and drive that femur into external rotation. So you're basically shifting your thought process away from looking at how the lower limb is actually decelerating forces, managing forces through knee flexion, ankle flexion. And then you're just completely shifting your focus towards force production to try to generate external rotation and avoid that internal rotation. So when you try to just look at this and say, okay, the client's struggling to generate forces into femoral external rotation and abduction, for example, then all you're doing is you're really just avoiding deceleration through the lower limb. It's a deceleration avoidance strategy. What we need to do really is we need to look at other strategies that the client has to decelerate forces via knee flexion. Okay? If the client has sensitivity here through the anterior knee, because when you move into valgus, it will certainly increase the compressive force between the patella and the femur. And we need to consider a few things. Are they experiencing that discomfort there because the knee is being overloaded there? The patellofemoral joint is sensitive to those forces because that's the only deceleration strategy that they have the capacity to express. Same thing applies. We need to consider other deceleration strategies that the client has. Okay? So it's really important to consider there that it's not just about looking at if you have a client that has sensitivity through the anterior knee. It's not always a case where the knee is being overloaded. Okay, I'll just run that here for you so you can see again. It's not always a case where the knee is being overloaded, but it may be it may represent that the individual has limited variability in the strategies that they can use to decelerate forces across the knee. Okay, so we need to consider that as well within the context of other strategies too. Maybe it might represent that the knee extensor mechanism is being overloaded and we need to distribute some forces into the hip and the ankle, for example. But we can't be too quick to shift the focus up into the hip. I think there's like I said, it's a knee-jerk reaction to shift that focus up into the hip and give the client clamshells and lateral walks with a band around the knees, instead of really trying to expose the client to other strategies to increase their solution space, if you like, around the knee to be able to manage and generate forces through the distal quadriceps. Generally, what I see is if a client's always expressing that valgus strategy and they don't have the capacity to express other strategies, that tells me that the distal quadricep doesn't have the capacity to manage and generate forces, and that's something that we need to look at. These next three videos here represent higher level assessment strategies to get an idea or get an insight into the rate of force development through the distal quadriceps, how quickly the distal quadriceps can build muscle activity to generate forces. So we'll typically start with a concentric reverse push here, where we get the client into a split squat position. We want them to express some tibial flexion and then quickly use the whole foot to push up and back into a standing position. Okay, and the key thing here is keeping the trunk upright. Okay, so we want most of that flexion and extension to come from the knee. Okay, but very often what you'll see is if the client struggles to concentrate that extension force at the distal quadricep, you'll see this hip strategy where you'll see this hinging of the trunk, this flexioning of the pelvis to try and distribute some of the force into the hip, into the glutes. Okay, so you'll see that here. So shift forward, we want to quickly push and reach back. What you'll see is, or push back. what you'll see oftentimes, you'll see this as they push, you'll see this hinging forward of the trunk, because they're just not confident in the distal quadriceps to be able to generate those forces concentrically. Okay. This will become more apparent when you're challenging the eccentric components. Okay, when you're challenging the distal quadriceps ability to manage those forces. So we're adding a little bit more coordinative challenge to this. We're asking the client to drop into a flexed position. We reach the arms forward here to keep the trunk back. So we're trying to reduce that tendency to hinge the body forward. But we want to see this quick transition from tibial flexion to tibial extension to push the body back the way. We want to see that nice knee flexion there. We want to see kind of a deep level of knee flexion. Okay. But what you'll often see is this strategy here where you might see some knee flexion, but you'll see that coupled with this hinging forward of the trunk, which still represents to us that they need the hip to help concentrate that extension force back into a standing position. Okay. When we do this reverse push, we're obviously putting a lot of focus on the distal quadriceps, and we're trying to reduce the tendency of the plantar flexors and the hip extensors to contribute to that extension force. Okay, so that's one key thing to consider there. What you'll also tend to see here in a client that has very significant limitations in the distal quadricep is as they plant, you'll see this shallow bend of the knee, so they're just not able to drop into that deep knee flexion. Okay, coupled with a hinge. So this will be a client that has a significant limitation in that distal quadriceps to be able to manage and generate forces at speed. Okay, so I would not be confident in this client returning back to running if, for example, they're post-op knee surgery, meniscal surgery, ACL, for example. Okay, I want them to feel confident in managing those forces and generating those forces through the distal quadriceps. Okay, so consider this reverse push relative to a forward hop. A forward hop would increase the contribution from the plantar flexors, from the hip extensors, because we're pushing up and forward. Okay, so I like these reverse pushes to really try and concentrate the forces through the distal quadriceps. Okay, so in the next slide, we're going to go through some case scenarios. Okay, so moving into 2 case scenarios here. So we're going to briefly discuss the subjective information, the objective information, and then use that information to help guide a certain thought process to determine what strategies the client may need to restore some level of variability, okay, on a muscular level and a kinematic level. So case number 1, we have a 35-year-old male experiencing right anterior knee pain. Okay, so again, we may need to consider PFJ versus TFJ in this scenario. Pain is worse during movement. So anytime pain is worse during movement, that should encourage you to consider the load sharing capacity across the lower limb as a whole versus the client that may have more pain at rest, where there may be a limitation in local contractile variability around the knee. So pain worse during movement, we obviously need to not just consider the knee, we need to consider the contribution from the ankle and also the hip. The client has a history of ankle sprains, so we do certainly need to consider the low capacity and the variability around the foot and the ankle to contribute to that flexion and extension with the knee. So, for example, if we have a limitation in extension at the ankle, which is plantar flexion, if we can't produce those forces very well, then potentially the knee extension mechanism may have to express more force production. There may be a little bit more load through the anterior knee. Now, that's not necessarily a bad thing all of the time. That's not necessarily going to cause pain, but we need to consider if the anterior knee is conditioned to manage those forces. Because you'll see plenty of clients clinically that have, maybe they're come to see you with hip pain, for example, and you check plantar flexion, they have really poor plantar flexion, but they have no pain around the anterior knee. So you can't necessarily make those connections straight away. You need to consider other deeper features as well, the low capacity and the capacity of that anterior knee to manage those forces. So it's not just the case where if one joint is unable to contribute to force production or force generation, the other joint is going to experience pain. It's not that simple. And we need to consider whether that joint is conditioned to manage and generate those forces. Okay, especially within the context of pain. Within the context of performance, that's another question. So looking into the objective assessment, the client had full tibial flexion and tibial extension, a good distal quadricep. Now, I can appreciate that we didn't really go through any real specific distal quadricep assessments in the last assessment slide, but we do need to have those assessment measurements as well. So we need to get a clear insight into how well the tibia can extend, okay, how well the distal quadricep can generate forces. We can use a dynamometer, we can use other assessments as well to get an understanding of how well that tibia can maintain flexion to drive that load into the distal quadricep. But again, like I said, a really good general assessment is looking at the behavior of the tibia as they extend the knee. You're going to see that in some of the rehab strategies that we go through as well. The client also demonstrated poor distal hamstring and soleus low capacity or coordination. So the distal hamstring, the soleus, wasn't able to manage forces very well, okay, and even up into the proximal gastroc too. So if we cast our minds back to the uncontrolled tibial extension video, we considered some muscles that may contribute to that feature, that quick tibial extension. Could be the distal quadriceps inability to maintain that tibial flexion. Could be the distal hamstrings, proximal gastrocnemius, their inability to decelerate that knee extension. Could be the soleus gastroc's ability to bring that load into the metatarsal heads, particularly the first metatarsal head, to be able to generate some extension torque via the ankle. Okay. So again, in this scenario, it may not be a case where we need to build a better distal quadricep, but we need to build a better distal hamstring, better proximal gastroc, better soleus, but then work on coordinating those the hamstrings, the plantar flexors together, but then also coordinating the plantar flexors and the distal quadriceps together to get them coordinating with each other. It doesn't mean we don't touch the quad. I think a lot of people are afraid to go after the quadricep, but from our perspective, it's a matter of understanding: do we want to concentrate force into the distal quadricep, or do we want to distribute that force across the distal quadricep into the plantar flexors as well, so they can both contribute to the flexion component and the extension components of force production. The clients also demonstrated poor plantar flexion with a soft knee, so that we saw that quick tibial extension there as well. Okay, so we need to consider that from our rehabilitation standpoint. So we need to go after the hamstrings, the soleus, their capacity and their coordination. We need to then coordinate that with the quadriceps, so coordinating plantar flexors and quadriceps, and then add perturbations to that. Okay. Case number 2, we have a 28-year-old female with left lateral knee pain. So we could be considering not just the PFJ here, but also the lateral knee and the TFJ, the tibiofemoral joint. The pain is worse when playing soccer. The knee generally feels unstable, but she has a history of a partial meniscectomy 4 years ago. Okay, she did go through rehabilitation. Rehabilitation really focused on a lot of hip and quad strengthening, but again, her distal quadricep was still very poor. The issue with her past treatment was that she focused a lot on squatting. In the research, what you'll see after any kind of knee operations is that when clients are squatting, they'll tend to demonstrate interlimb compensations where they'll shift more force into the opposing knee to generate that extension torque. So they're not really challenging that quadricep on the affected side. But you'll also see intralimb, a lot of intralimb compensation as well, where they'll generate more force into the ankle extensors or hip extensors, not the knee extensors. Okay, so we need to consider that during rehabilitation as well. During the objective assessment, during the small knee bend, single leg squat, small single leg squat, we saw significant valgus and pain at the anterior knee. So we saw some sensitivity through the PFJ here in this example here. Okay, we need to again step back and consider, okay, is this the only deceleration strategy that the client has? And it was, because the distal quadricep was really struggling to manage forces. We saw limited knee flexion and limited tibial internal rotation. So there's some local stuff that we need to do around the tibia and femur. Or distal quadricep, good hamstring, good strong hamstring. She did a lot of isolated work around the hamstring, but she also had some limitations distally. Right? She had a poor capacity to distribute that load into the first metatarsal head during a calf raise. Okay, so she had a very rigid arch, very supinated midfoot, an inability to demonstrate that calcaneal eversion, which is another important feature around the foot and ankle, complex to express good deceleration characteristics. So we may need to go after that as well. But generally, the key things with this assessment and from a rehabilitation standpoint is to improve knee flexion. We may have to use both manual and active loading strategies as well. We need to build better distal quadriceps capacity and then start to coordinate those plantar flexors with a bent knee. Okay, because just like in this scenario here, where we had a good distal quadricep but poor plantar flexion capacities via the soleus, we wanted to coordinate them together. In this scenario here, we want to coordinate the distal quadriceps and the soleus together eventually, but we need to first focus on building the load capacity of each individual muscular tissue before we work on coordinating those muscular tissues together. Okay. So going into some early loading strategies, we want to try and facilitate, and this is for case 1. This is for the first case here, the 35-year-old male experiencing right anterior knee pain. So early on, we want to try and get some load into the hamstrings, distal hamstrings, and the soleus. So we can use this wall calf raise strategy here. I'll bring this into the full screen, where we're keeping the opposing limb not very flexed, we're keeping it very close to the target side. That's going to increase the mass that the pelvis needs to extend against. It's going to increase the challenge on the plantar flexors and the tibial flexors as well, which is the distal hamstrings. We can hold that position there isometrically, or we can start to challenge the dynamic motion around the ankle. Typically, I like to have clients work up to 30 to 40 reps in this position, just to really challenge that capacity through the soleus to manage and generate those forces while we're getting some load into the distal hamstrings as well. I really think we should be able to achieve at least 30 repetitions in this position here, because gravity isn't really acting down on the ankle extension component. There's a much greater emphasis on tibial flexion here to generate force against gravity, and then we're making it easier for the ankle to generate forces into extension there. So a nice early loading strategy to give the client the experience of that load through the distal hamstrings and the soleus in more of a coordinated manner, but also in a manner that allows the soleus to experience that load much easier. Okay. Then we want to increase the challenge on that. So remember, this client had a good distal quadricep, but poor distal hamstrings and soleus coordination. So we eventually want to challenge that tibial flexion component as well. So what we can do is we can use this different strategy here, where we have the metatarsal heads on the edge of a chair. I'll typically have the client keep their shoes on because it provides a better platform to position the foot on the edge of the chair. We have that non-target side extended as well to increase the amount of mass that this limb has to extend against, not just extend against, but we're flexing against it as well via tibial flexion. We're going to feel a lot more challenge here through the distal hamstrings and the calves, okay, particularly the soleus, and you'll feel some load up into the proximal gastroc here as well. But we can hold this as an isometric strategy, working towards holding it for 45 to 60 seconds, and then we can add in more of a dynamic femoral extension component too, where we're actually trying to drive the pelvis towards the ceiling, drop it back down, and add more dynamic motion or dynamic perturbation to the capacity of the distal hamstring and the soleus to coordinate with each other. If we wanted to really challenge things even further, especially through the distal hamstrings, we can use a strategy like this, where we're using a foam roller perturbation. And this is a clip from a recent course, level 1 course in Hong Kong, where we have the client get into a bridge position with the forefoot in contact with the foam roller. And we can manipulate the amount of flexion at that tibia. So we can keep the tibia more flexed at the beginning, challenge it by pre-positioning it into more extension. But what the client's doing here is the therapist in this case is bridging the pelvis, holding that hover proximally, maintaining that load through the foot. And then this therapist here is perturbing the foam roller by pulling the foam roller towards himself. What this pulling of the foam roller will do is it will try to extend the tibia at speed. And this is going to challenge the distal hamstring to maintain that tibial position. So as you quickly move the foam roller, it'll try to extend the tibia. That's going to really challenge the reactive capacity of the distal hamstring. And you can see in that video there that the therapist was struggling to get through 5 to 6 repetitions of that. Okay, so we're trying to extend the tibia at speed and really challenge the distal hamstring's reactive capacity. As an example of how we can coordinate the distal quadricep and the plantar flexors together is by using this pelvic hover. Okay, so we like to use this position here as an initial strategy to build that coordination. Typically, when we're trying to build better coordinative characteristics, we like to work on strategies that are more concentric dominant, because this makes it easier for the nervous system to really determine how much muscle activity they need to build muscle tension. Whereas sometimes if you might find yourself working with clients, if you have to ask the client to express some kind of eccentric behavior and concentric behavior, sometimes that can be too coordinatively challenging. So that's why we have them starting in a seated position, okay? And we're having the wall in front to try and reduce that balance demand. What we want to try and do here as well is incorporate the hip with the ankle. So we're actually getting some pelvic flexion here as well, even though relative to the rib cage, the flexion of the rib cage, the pelvis is extended. So we do have a slight flexion of the lumbar spine. That just helps us to concentrate some of that extension at the knee a little bit more. But what we want to try and do here is we want to elevate the heel very, very slightly here and maintain that heel hover, that heel elevation as we build pressure through the metatarsal heads and then hover the pelvis from the chair. Okay, you can see the shaking there. This is a very challenging strategy. But one of the key things here is maintaining that tibia in flexion. The reason that is because when the tibia is biased towards flexion, and sometimes we don't have to go into this much flexion. Sometimes I'll start the client with a toe just beneath the knee. But when that tibia is in a position of flexion, gravity and the mass of the head, arms, and trunk is trying to further flex that tibia. So if gravity and the mass of the head, arms, and trunk are trying to further flex that tibia, that's really going to challenge the distal quadriceps ability to maintain that tibial position. Okay, that's why sometimes if clients struggle to maintain that tibial flexion position, you might see that a quick snap back into tibial extension because the quadriceps don't want it. It may be also represented by a deviation into valgus because the quadriceps don't want it. Okay, but you'll typically see that during the eccentric component and the deceleration component of force management. But key thing here is the setup. Set up on the right position, pre-position the segments in the position that you want, tibial flexion, some lumbar flexion, pelvic flexion, heel hover. And we typically start with just a small heel hover for 5 seconds. Repeat that for 5 to 6 repetitions. Okay, and then gradually build to the point where we can hold it for 10 seconds, 15 seconds, all the way up to 30 seconds, 45 seconds. And then we can add a little bit more of a dynamic component to it as well. Okay, so static hold, 5 seconds, up to 6 reps, even up to 8 repetitions as well. But we can progress to adding more dynamic femoral and tibial extension. And just to talk about that biomechanical representation there as well. So when we're extending here, we're really extending the femur. The tibia is staying in a flexed position. If we had to extend any further, the tibia would have to extend, okay, with the extended femur or the extending femur, okay? So it's all about more the coordination between the extending femur and the extending tibia. Early on during the force production, we want to keep that tibia flexed and maintain that position. That's why we just do a pelvic hover and we don't go through a bigger dynamic movement through the femur and the tibia, okay? Especially in those clients that struggle, which you'll see in the next case, especially in those clients that really struggle to handle those forces through the distal quadriceps. But remember, the key thing here is that we're not necessarily trying to build better distal quadriceps here. We're trying to challenge the coordination of ankle extension and knee extension with some hip extension as well. And we find this a really, really powerful strategy for clients that are really struggling to distribute forces across the lower limb when they're quickly expressing an inability to maintain variability. So sometimes you might see that inability to maintain that tibial flexion because of a poor distal quadricep. But again, during the objective assessment, we established that distal quadricep was able to manage and generate forces, but it just struggled when you added in a multi-segmental or a multi-joint perturbation. Can it do it while the ankle does something as well? Is essentially what you're asking, because that's important in real world situations. Okay, so next we're going to go into case number 2 and the rehabilitation strategies. Okay, so moving into case number 2. So again, just to revisit the objective assessment there, we had limitations in knee flexion and tibial internal rotation. So we will need to use some manual strategies to try and facilitate some knee flexion and tibial internal rotation. because we ultimately need the space in knee flexion to be able to allow the distal quadricep to experience that load to manage and generate forces. We can't just jump straight into challenging the distal quadricep to manage and share forces if we don't have the space from a joint segmental standpoint and a local contractile variability standpoint. Okay, with a good hamstring, we also have poor metatarsal head, first metatarsal head contact during the calf raise. Whenever you see poor first metatarsal head contact during a calf raise, there's many ways we can facilitate that metatarsal head contact. One of the key ways to do that is by actually doing things that challenge plantar flexion with more of a bent knee. Because with a bent knee, you're going to facilitate greater capacity to internally rotate the tibia. And that internal rotation of the tibia can help facilitate some load distribution into the medial portion of the foot to try and drive that load into the first metatarsal head. It doesn't mean that that's all we need, but within the context of this knee masterclass, that's what we're going to focus on here. Okay, there was some other things that we needed to do. Because obviously if we extend the knee, we're going to facilitate more of an external rotation of the tibia, which is going to drag the foot into more of a supinated position, an externally rotated position, which is going to drag us away from that medial portion of the foot, which is where the first metatarsal head lives. Okay. So key things that we want to focus on first, trying to facilitate knee flexion. Let's talk through some manual strategies. So we're going to use this prone tibial internal rotation strategy here too, or first to try and facilitate more muscle length change through the rec fem, okay, and try and spread that load over this muscular tissue. But we want to couple that with some joint segmental variation as well, in the sense that we want to try and drive tibial internal rotation as we progressively improve knee flexion as well. So we'll take the client, we'll pre-position the client into a position of knee flexion. Typically we'll do it at 90 degrees first, where the client is in a comfortable position, or where we're pretty far away from the client's barrier. Okay. Then what we want to try and do is clasp our hands around the foot in this way to ask the client to generate force into tibial internal rotation. So we're generating that force statically. We're holding it as an isometric hold. But then what we're doing is we're changing the position of knee flexion. Okay. Then we can progress towards maintaining that tibial internal rotation force production. And then we can dynamically move the knee into flexion and extension. Okay, so she's maintaining that force into my hand. I'm dynamically moving her through flexion and extension. Okay. Lastly, that's not shown here. What I like to do is I like to try and get some force into the rec fem, particularly through the distal quadriceps in this lengthened position. So what I'll often do is I'll often pre-position the tibia into internal rotation by grabbing around the distal tibia and fibula. I'll internally rotate, and then I'll ask the client to extend the tibia into my hands. So I'm still facilitating some internal rotation of the tibia, but now I'm asking the client to not generate torque into internal rotation of the tibia, but I'm asking them to generate torque and force into tibial extension. So we can start to get some load into the distal quadriceps in more of a lengthened position, okay, which is going to be important for me to be able to flex the knee, flex the tibia. Another option that we have here is a more of a supine dynamic tibial internal rotation strategy, where we're using a foam roller or a medicine ball here to get a dynamic tibial flexion and extension. So it saves your arms, especially if you're working with a big client with a lot of muscular mass around the lower leg. You're trying to keep you're trying to hold the leg in space to flex and extend the tibia, which can be quite difficult, especially if you're trying to facilitate an internal rotation moment at the tibia. So I like to have the client position their foot on a medicine ball or a foam roller, which saves my biceps because I don't have to hold things up. And I just apply a tibial internal rotation and then have the client gently move the foot back and forth. The client doesn't have to actively pull it back at the very beginning. You can start with that, but it just allows for a much smoother transition into knee flexion and knee extension as I rotate that tibia as she's flexing the knee, or as I'm flexing the knee, depending on where your starting point is. You can start passively because you have the ball there to do the work for you, and then you can challenge things by asking the client to gently push down into the medicine ball or the foam roller to get a little bit more active contraction through the hamstring. Okay. Another thing that we like to use as well is a strategy to try and get a little bit more rotational dissociation between the tibia and the femur while still trying to get some load into the hamstrings. Now, of course, the client has a good hamstring here, but we can utilize a strategy where we're in more knee flexion, still getting load through the distal hamstrings, but at the same time now the focus is on trying to facilitate some tibial and femoral dissociation with the distal hamstring, okay? So the key thing here is bridging up, holding that bridge position, and then asking the client to rotate the tibia first, maintain the femoral position here. So you can see the femur didn't move, the tibia externally rotated. So in that position, we're expressing dissociation where the tibia is rotating into external rotation, lateral rotation, and the femur is biasing more of an internally rotated position relative to the tibia, okay? And then we can ask the femur to follow. And then from this position, we're internally rotating the tibia relative to a more of an externally rotated and abducted position, okay? So tibia rotates first, then the femur follows. And at the same time, we're holding onto that distal hamstring contraction, but keeping the pelvis bridged proximally. But most of the force production here isn't necessarily through femoral extension, it's through tibial flexion. Okay, so a really nice strategy to use there to try and facilitate a reduction in the co-contraction between the tibia and the femur. So a nice one to use in combination with the manual strategies here. Then we want to try and think about quadricep and soleus loading. Okay, so one of the key things when it comes to loading the quadricep and the soleus and trying to get deep into knee flexion is that the soleus will also have a very important feature in decelerating the flexion of the tibia. So it acts as an agonist to the ACL to control that anterior tibial translation. So sometimes what I see clinically is that if the client has an inability to manage force as well through the soleus, but they still have a good distal quadricep, they still don't have the confidence to move into knee flexion at speed until we actually get some direct load into the soleus, okay? And the reason that is here is because ultimately the soleus is distal to the quadricep, and we have to respect that the foot and ankle segment is the first segment to interact with the external forces, with the environment. So while we still need to build a good distal quadricep, we need to consider the interaction with the soleus as well, because of the importance of the soleus acting as an agonist to the ACL and to the deceleration of tibial flexion. Because remember, if the tibia flexes too quickly or it's not controlled well, that still also represents a distal quadricep that can't maintain tibial position. Okay, so one strategy that we like to use here, especially early on with clients that may have a poor capacity through the distal quadricep, is this door frame constraint. Because what this really allows us to do is to reduce the challenge on femoral extension and tibial extension, because we can drive that force up and back into the door frame here. Okay, so we're propping the femoral up onto a block here. We can manipulate the starting position of knee flexion here as well, but because of the angle of the foot here, we're not having the foot on the ground. If the foot was on the ground here, for example, we'd just be fighting the ground away, so we're just driving force through tibial extension, not really through plantar flexion. Okay, to elevate the heel and then drive that force down and backwards. Okay, so we're trying to drive force in this direction here, and you'll really feel that load start to distribute into the soleus. You will feel the quads working. You will feel some load into the glutes as well. But again, it just provides a much nicer strategy for us to get that strong isometric load into the soleus. If you don't have the weight to put on top of the femur, for example, in a bent knee seated calf raise, for example, or a soleus isometric hold position, I just really like it for that purpose, because many clients have foam rollers. They have access to foam rollers. They can prop the foam roller up onto something at home like that, and really drive that load into the soleus, but at the same time challenge their ability to maintain knee flexion. Okay, so we have more variability expressed at the knee in this position as well. Okay, so it's not necessarily a strategy utilized to improve the coordination between the distal quadricep and the soleus, but just a nice constraint to use to really isolate that force production through plantar flexion because of the constraint of the door frame. Then we really want to try and start building a distal quadricep. Okay, now when we're trying to build a distal quadricep, we need to think back to those compensations that we spoke about before. where we can have, we can have interlimb compensation, where we're shifting that workload into the opposing limb, or we have intralimb compensation, where we're distributing some workload into a neighboring joint segment. Very often what you'll see is a client shifting workload into the plantar flexors or hip extensors. Okay, so what we want to try and do when we're trying to build a good distal quadricep is we want to try and reduce that plantar flexion contribution and reduce that hip extension contribution. So we don't want to see that hinge forward here. Okay, it's okay to get a little bit of a hinge. We don't want to see a strong hinging sensation here. I don't think this strategy here shows a really strong hinge. Not necessarily. We see a small hinge at the beginning, so we can get a small bit of contribution from the hip, but the key component here is actually driving the force through the heel. Sometimes with clients that have difficulty getting load into the distal quadricep, they may have limitations in ankle flexion, so we can elevate something under the heel, as we'll show you in the next video, that can really help with that crushing of the heel. But we do want to have the wall in front here to prevent too much trunk flexion or pelvic flexion, okay, where we're utilizing the hip extensors to contribute to that extension torque, okay? But the key thing here again is the setup. We have tibial flexion, hands in front to reduce the balance demand. We can hinge forward slightly, okay? But we're not really trying to get too much pelvic flexion. We're getting a little bit more spinal flexion here, okay? And then the key thing here is, here's the key cues here. We want to crush the heel downward into the ground, crush the heel down, but simultaneously try and drive the tibia or the knee forward. If you get that cue right, you'll feel your distal quadriceps light up like you've never felt before. So it's the simultaneous crushing of the heel downward into the ground, not pushing away, not pushing behind, but downward, and then the simultaneous reaching of the tibia forward, not to the point where we're trying to lift the heel off the ground, but we're just trying to maintain that gentle reach forward. And you'll really feel your distal quadriceps light up. So we can start with a small pelvic hover here, and then we can gradually progress towards more of a dynamic femoral motion here. We're getting a little bit more extension through the femur, as you'll see here in a second. So because we're in a deeper level of femoral flexion here, we're certainly not just loading the distal quadricep here. We're going to get into some strategies in a few moments where we're really isolating the load into the distal quadriceps. Because if we have a distal quadricep that's struggling to manage loads, we don't want to just throw all the load at it straight away. We need to consider that the load capacity, the load tolerance of that distal quadricep is quite low. So if we throw too much isolated load at it too quickly, we might make it grumpy. Okay, so we do want to get some distribution of our contribution from other joint segments during the early phases. Okay, so it might be okay to use a heel hover strategy. It might be okay to use a little bit of a hip hinge at the beginning. But if we wanted to try and reduce that tendency and try and get some initial load into the distal quadricep while trying to get some contribution from neighboring structures and muscular tissues, then we want to make sure that we try and reduce that hip hinge. We try and keep that heel driving down into the ground. But because the femur is flexed here, we are going to be getting some load through the glutes. We are going to be getting some load through the proximal hamstrings. We're going to be getting some load through the adductors, not abductors, during the force production phase here. Okay, but the key thing that's going to help you kind of consider the behavior of the distal quadricep is the position of the tibia. That's the key thing. Okay. Okay, so in this next video here, you're going to see a towel position under the heel. And what this does is it helps clients that don't have that flexion capacity, that flexion space at the ankle, to actually bring the tibia into a flex position. But what it also does, even if the client has that space in the ankle, positioning a towel here or some kind of elevation. I like a towel because it just gives us a little bit of yield, a little bit of give, so we can really squash the heel down into the towel here. What it does is it helps us to bring that tibia into more flexion, but really concentrate on that heel drive downward. Okay, so in this position here, if you were to try this one relative to the previous video here without the towel, and of course what you're seeing here, I forgot to mention that you're going to see a more of an upright trunk position. So because we don't have that flexion challenge from a space standpoint distally, it means we don't have to flex the proximal structure too much, because now I can concentrate a lot more flexion at the tibia. Okay, so if I can concentrate a lot more flexion of the tibia because I've elevated the heel, it means my trunk doesn't have to come as far forward to be able to get force down through the foot. Okay, because I do have to get my center of mass over the middle of the foot to be able to drive that force down. If I don't have enough knee flexion, I'm going to have to bring the trunk forward, the pelvis into more flexion. So that's one of the benefits of this strategy here too, because it allows us to keep an upright trunk and really reduce any contribution from the hip, really reduce any contribution from the plantar flexors. So we can really concentrate a lot of load into the distal quadriceps. But still, we're starting from a deeper position of femoral flexion. So we're still going to be getting some load into the glutes, into the proximal hamstrings, and into the adductors as well. Another strategy that we can use to lighten up the body weight is by using this band setup here. So we can attach a band, anchor a band above to lighten the body weight, get into a deep position of femoral and tibial flexion, and then drive that force down through the heel. We can work dynamically, or we can work using more of a static hold. Okay. But again, the band addition here just lightens the body weight, makes it a little bit easier for the client to maintain the position and be able to express a couple of repetitions. Okay. But one of the key things with this one here is that we're actually allowing for the femur to move through a little bit more flexion here relative to the tibia. So we're going to be getting a lot more length change through the distal quadricep here as well with the addition of the band. What I want to show you here is more of a quadricep and soleus coordination strategy too. Excuse me. Typically, you'll see this strategy being done by a lot of people with the intention of trying to get more load into the soleus. But I don't really see this as a soleus exercise. So you're getting into a split squat hold and then you're driving the ankle into plantar flexion, dorsiflexion. For us, this is really more of a coordinative strategy where you're trying to challenge the isometric behavior of the distal quadricep and then perturb that with a dynamic ankle. You're still getting some load through the soleus, but you're not really getting a huge amount of load through the soleus here, okay? Because a lot of the force is being challenged through the tibia here, okay? Not necessarily through the ankle, okay? So because we're not really producing force, we're not really getting any vertical displacement of the mass here. The head, arms, and trunk are staying in the same position. The only thing that's really moving is the femur. So the plantar flexors aren't really producing much force at all, just through the femoral segment, and some level of force from the head, arms, and trunk. Sorry about that. But what we can do, we just need to shift our intention. So like I said, the intention is not necessarily to use this as a strategy to build a better soleus, but just to get some level of coordination between the distal quadricep and the plantar flexors, the soleus in this scenario, but also can help us, give the client the experience of getting some load into the first metatarsal head, which this client in this case had difficulty with. In this video here and this picture here, not necessarily in this picture here, you're going to see a lot more concentration of load into the distal quadricep, okay, with this wall sit variation, okay. So this one really allows us to reduce any kind of contribution from the hip and from the femur, okay? Because what we're doing is we're sliding down, we're keeping the heel probably about a half a foot away from the wall. When we have a small step with the foot, we obviously we can bring that tibia through greater level of flexion, okay? I'm just going to back out of this for a second. If we took a big step as we slide down the wall, then that tibia is still not going to come through much flexion. It's still expressing more of a vertical orientation here. So the gravity is not really challenging that, is not really trying to push that tibia into more flexion, okay? There's more of an axial load through the tibia. So the distal quadricep isn't really going to be challenged as much here. So if we're trying to challenge the distal quadricep, we need to take a small step and allow for the tibia to flex. But the key thing there now is really driving that load again, like I said, through the heel, and simultaneously drive that load forward through the knee, or reach the knee forward, reach the tibia forward, okay? And then maintain that position. Okay, but again, in this position here, this is really the position. If you get the cues right, if you really concentrate that force downward into the heel, and then really reach the tibia forward, not to the point, like I said, where you're coming up onto the toes and lifting the heel, you'll really feel a strong burning sensation into the distal quadricep. And we can progress by adding more load, external load, or sliding further down the wall to bring the tibia into more flexion. Okay, but really the intention here is to really drive that load into the distal quadricep. Now what we want to try and do is try to add a bit more speed, a bit more ballistic nature to the distal quadricep loading strategies. So we're going to talk through more of an oscillatory split squat variation here. Okay, where we're going to begin in a low split squat position where we have some nice tibial flexion, we have some nice femoral flexion. But what we're going to try and do here is add a low concentric push and a catch, but the catch is not going to be stiff. The catch is going to allow for a little bit of a sinking into more femoral flexion. Okay, we're not really going to be sinking a lot into tibial flexion. Okay, but a lot more through more femoral flexion, which is still going to flex the knee. But the key thing here is that we're trying to maintain the tibia biased towards a flexion behavior. Okay, one of the key things that you have to consider here, I'll run the video in just a second, is that if we have a very stiff and braced knee, where we're not allowing that knee to flex under load at speed to give the distal quadriceps a chance to manage forces, what we're doing is we're reducing the time that the limb has to distribute forces. When you reduce the time, then that time is represented by muscle length change and joint angle change. When muscle length changes, when joint angles change, that takes more time. When you give the system more time to manage and to manage forces and decelerate forces, you help to distribute those forces over a broader surface area. When you reduce the time, which will be represented through less joint angle change, less muscle length change, which will be represented by a stiff braced knee, a co-contraction, then you concentrate force into certain areas. That can be very important from a performance standpoint. But if you're using that strategy in situations where you should be flexing the knee more, let's say you're coming into a really high intensity horizontal change of direction, okay, or change of direction where you have to sink into knee flexion, there's a lot of force, a lot of speed behind it, a lot of momentum that you have to manage, and you're landing with a stiff knee, then you're not really giving the knee many options to decelerate. And that's when you may see that valgus movement where the knee has to decelerate the force in some way. So it moves into a valgus position. And with a braced knee and the valgus position at speed under high force, I think that's a situation that can be troublesome, okay? Because there's an inappropriate strategy being used to manage and decelerate forces relative to the demands of the task, okay? So I just wanted to kind of give you an insight into that as to why we're using this here. We're keeping the knee in a flex position. We're sinking down to it with a little bit more of a soft landing to help distribute those forces over a broader surface area. But what we're doing here now is we're not overloading the distal quadricep too quickly, but we're coupling that with the soleus. Okay, so we're trying to challenge the isometric behavior around the foot and the ankle. Now, if we were producing high forces here with the concentric push, we'd have to push through a whole foot. We couldn't produce force through the balls of the feet. That's why we're keeping the concentric phase low intensity, a low push. Okay, and cast your minds back to what I said about the soleus as well. If we still have a good distal quadricep, but we have a poor soleus, then I think that disrupts the confidence that the client has in shifting more flexion into the knee, okay, at speed especially. So set up in the same position, we can get a little hinge, so we're getting some load from some contribution from the hip here, but again, a low concentric push, and we're sinking down into this more hip flexion or femoral flexion there, okay? But just watch the tibia here. Keep the tibia biased towards flexion. You're going to feel that load through the distal plantarflexors. You're going to feel a lot of load into the distal quadriceps as well, okay? But really, what I really want to get back to with a lot of these clients, especially post-op ACL, any kind of post-op knee, where there's been some inhibition through the quadriceps, for example, and they struggle to build muscle activity quickly at speed. I really want to get to this strategy here where we can do that, but with the heel crush, not with the metatarsal heads. We're trying to keep the metatarsal heads quiet in this one. We're trying to crush the heel downward. Okay, little hinge, driving the load down, really crushing the heel down to the ground, even as we decelerate into it. But again, like I said, you'll really feel your distal quadriceps light up like never before if you're really crushing that heel down, okay? But like I said, we're just adding a little bit more speed. We're reducing the coordinated complexity with this because we're not adding a strong eccentric component or a really strong concentric component, but we're just trying to challenge the maintenance of that tibial flexion at a bit more speed, challenge the ability of the distal quadriceps to manage those forces and generate low forces at speed as well. So you can think of this transition from this video here to this video here as we're distributing extension across the ankle and knee here, but now we're concentrating that extension and flexion at the knee in this video here, okay? So lots of things to think about there. Two different case scenarios with different features, but the key thing is the sequencing. I think I don't want you to think that you need to get the sequence right with every rehabilitation or rehabilitation process, because it's not necessarily going to always unfold in a linear manner. It almost never will. But what we need to do is we need to really highlight the limitations that the client is expressing, both from a kinematic level and a kinetic level, and then integrate these neurological features on top, okay, that we spoke about at the beginning. Okay, and that's what we really try to do in our level 1 course and level 2 course. Okay, so if you want to learn more about this, again, I appreciate all of you for taking the time to sit through and watch the recording. Hopefully, I really hope you enjoyed it. But if you want to learn more, I think the next level 1 course is up for registration in August. The next cohort is ready in August. So if you want to learn more, you can reach out to us, ask us questions about the next cohort. If you have any questions about this masterclass, please reach out to us as well. And look, thanks so much for listening. Again, I'm not great at marketing new material. I just like going through the content. I really like working through these features and exposing people to these different features. It may be something that you've heard before. It may be something that is completely new to you, but hopefully it gives you some practical information that you can take into clinic the next day. I think even just simply thinking about the thought process of not always thinking the knee is taking too much load and trying to shift more load into the hip and the knee. But hopefully this gives you more strategies that you can utilize in a step-by-step process to expose the knee to different strategies to decelerate forces and generate forces, okay? So like I said, if you want to learn more, please reach out to us, and hopefully we'll see you on a level 1 course soon. Thanks again.